Hi, I'm Bob Harrington from Duke University. I'm here at the American College of Cardiology meetings in New Orleans, and we thought we'd take a moment to reflect upon some of the trial results we've had from some of the technology-oriented trials to address, I think, a really pertinent question about how some of this technology will diffuse into clinical practice, and that is this notion of the heart team. So I'm joined here by two colleagues, Mauri from Boston, interventional cardiologist, Neil Moat from the Royal Brompton, a cardiac surgeon. And I think having the two of you is going to be critical, because what we want to do is talk about this notion of aortic valve replacement, either percutaneously or surgical, mitral valve repair, percutaneously or surgically, left main surgery versus percutaneous intervention. You get the picture. Mm-hmm. And one of the key elements that I found fascinating in all of the trials that were done is this notion of the heart team, that you have to have a group of people who come together from different disciplines, evaluate that patient, evaluate the situation, help decide if this patient is appropriate for these technologies, and then provide all of the support for that group of patients along the way. Echo, CTA, interventional, surgery. So let's start with you, Neil, because you've been very involved with the transaortic valve studies and the procedure itself. Talk a little bit about this notion of the heart team. What's the philosophy behind it?
I think it's something which goes back quite a way in time with surgery and the infancy of PCI. And when PCI was starting, all the patients would be discussed with surgeons and the early interventional cardiologists. And I think perhaps the volume of that work created a change. I think what we see now in the patient populations for transcatheter valve therapies and maybe complex coronary interventions is these patients are much older and much sicker than many of our patients, and they have very many problems. And what we're seeing is that there are now a number of options for these patients. Medical therapy, which is quite complicated, sometimes involving some device therapy, surgery, and the raft of new transcatheter techniques that are coming along. And to evaluate the patients requires a set of skills that no one group has. So the surgeons don't have all the skills, the cardiologists. And I think in a lot of these patients, the imaging assessment, the preoperative imaging and planning is key. So you need expert echo people, expert CT, CMR in certain instances. In our institution, we also involve care of the elderly physicians in some of these decision-making in these octogenarian patients. And I think that it's reinvigorated in some ways, I think, the hospital in getting all these teams, getting these people together and discussing these complex patients. But I've got no doubt in my own mind that it really does benefit patient care. And in order to have success with the transcatheter techniques, I believe it's absolutely essential to have that team approach. And unfortunately, that really means you're committed to being in a big centre where all of those, is there.
Laura, when I trained as an interventional cardiologist, very much what Neil is saying, that we had cath conference where we talked about the cases. In part, we had to, because the cath lab we had to have an operating room on hold while we did the procedures. Mm-hmm. But that evolved. Stenting, more potent antithrombotic therapy. Interventionalists by the mid-90s, late 90s, didn't think like that anymore. We just went ahead. And one of the criticisms that we as a community have had put upon us as interventionalists, well, you're the guys making the decision, and you're not calling the rest of us because you can do it yourselves. How do you want to react to that in this new environment of much more complex patients, much more complex technology?
Yeah, I think I don't think we've ever evolved completely away in those really complicated patients, even in coronary disease, of, at least in our center, really working together with the surgeons. I mean, there are many cases where even before syntax, we knew that there would be trade-offs between a surgical approach versus a percutaneous approach, and really trying to present a balanced viewpoint to the patient, but also to the referring cardiologist. I think that to take a step back, aside from just the interventionalist and surgeon, there's a very important role for the non-invasive cardiologist or sort of the person who's not doing the procedure to be able to consider these things. They may not be the expert in each of the individual techniques, but they can help the patient to consider the various risks and trade-offs, because they're really very dissimilar procedures. For the example of PCI versus bypass surgery, in terms of comparing some of the trade-offs, we've all had these conversations where there is more of a chance that the patient will need more procedures in the future, and that is to be traded off with the relative potential benefits of having a less invasive approach.
Neil, a lot of what Laura's describing, certainly what goes on at our place as well, but I would define that, or maybe say that it's informal. I have a challenging case. I call my colleague, I say, geez, let's think about this, let's go talk to the patient together. But what you're describing goes really beyond that. When you're talking about complex aortic valve disease, this is truly getting a team of people together with all their pieces of expertise. Yeah. How does that work?
You're exactly right. I think it's moving beyond grabbing a colleague and saying, what do you think about this surgery versus PCI? It works by setting time in the week where the cases are presented, and you have to have a facility where all of that imaging can be seen, and members of the individual team, surgery, cardiology, and I agree with Laura's point that it's actually very useful to have cardiologists, non-interventional cardiologists, and perhaps also surgeons who are not involved in transcatheter techniques to give a balance in the field. But it requires time and a commitment to actually sit down and go through the cases. But I genuinely believe it is worth it, and I think some of the results that we see in the trials and the registries with the transcatheter techniques are really fantastic, given that these are very sick patients and with first-generation technologies. And I think a lot of that is to do with this true multidisciplinary approach. And it's multidisciplinary in a room, going through the patient, talking about the different access routes, the various nuances of how you might get the valve there, what you're going to do with the valve, how does that balance up against how complex the surgery might be, what about their renal function, how good or how bad is that? And the only way to achieve that, I believe, is actually having that team in a room, formally engaged. Mm-hmm. And then I think when you have that team then moves into the lab or the hybrid lab, and not everybody, but it engenders that total team behavior in the interventional suite, be it theatre or lab. And when we have a situation where I think the surgeon and cardiologist are completely interchangeable in our transcatheter valve program, both for transfemoral and other procedures. And okay, it's possible to do it a different way, but there's no doubt in my mind that is the ideal approach. That is the ideal way to do it.
So, Laura, let me ask you two questions, maybe much more from the American perspective or the U.S. perspective. One question is that you've been one of the leaders of the mitral clip program, and clearly in an investigational setting, people are willing to put egos aside, if you will,